Good evening. Good evening, all of you. Am I audible and visible? Hi, Hemant Kapoor. If I'm audible and visible, can I see a thumbs up, please? Yeah, so today's session is an image-based MCQ session for the upcoming, thank you, Maheshwari. So this is an image-based MCQ session for the upcoming May 2023 INI-CET. And in this session, I've chosen few high-yield MCQs. Yeah, using few images, I will be explaining a few inborn errors of metabolism, a few molecular genetic related MCQs. Okay, so that's an outline of the session. But before we start the session, let me tell you a few must-know topics of biochemistry, because I see that many of you have been, you're not able to hear me, Isha Singh? Good evening, Ankit. Good evening, Sujit. Hi, Sunil Kumar, Isha, Preeti. Hi, Dhruv Sharma. Isha, I think you should check your side, check it from your side. I'm able to hear myself here. Okay, so must know topics of biochemistry, because many of you have been asking me this. So the first must know topic would be molecular biology, right? Yes, hi, yeah. So it would be molecular biology, because exactly 1 year back, here in May 2023, out of the 7 MCQs which were asked in biochemistry, 5 were from molecular biology. And all 5 MCQs were related to techniques. They were related to Human Genome Project. So please do not forget to learn about molecular biology before you go for your INI-CET exam. Okay, and apart from molecular biology, you will have to learn about inborn errors of metabolism. And among inborn errors of metabolism, I know it's a very long list, right? It's not practically possible for you to learn about all inborn errors of metabolism. But what you can do is you can learn about glycogen storage disorders. Without fail, please learn about glycogen storage disorders. Glycosphingolipidosis. So in rapid revision video on PrepLadder, I've explained, I've given you shortcuts to remember few facts which will help you to answer MCQs based on glycosphingolipidosis. And similarly, mucopolysaccharidosis. That's about inborn errors of metabolism. Discuss strategy also, how to go for INI-CET. Just few days left. Yeah, definitely I will tell you. Yes, this is useful for any exam aspirant. Okay, it need not be INI-CET, FMG, NEET, PG. There is not much of difference between any of these exams. It's all conceptual MCQ, which you'll be able to answer if you learn the subject conceptually. Okay, so please attend the session. Okay, I will definitely do it, Preeti. And apart from inborn errors of metabolism, vitamins, right? Vitamins, why do you think many questions are asked on vitamins? It's because vitamin is like a congregation of all metabolic pathways. Every vitamin will be used as a coenzyme or as a cofactor for almost all the metabolic pathways. So you will not be able to answer an MCQ on vitamin if you don't understand metabolism. And that is why they keep asking you questions on vitamins. Okay. And apart from vitamins, ABG reports. Thank you, Parth. Yes, vitamins linked with other subjects also, exactly. So ABG report analysis, please get yourself familiarized with reporting arterial blood gas analysis reports. Interpreting these reports is essential, not only for you to be able to appear in INI-CET exam, but also for you to be a good clinician, okay? And apart from ABG report is regulation of metabolic pathways, because like it might look like a one-liner, but if you try to understand that question, it will be a conceptual, complex concept that is asked. Okay, so regulation of metabolic pathways is also important. Okay, so these are the topics that you will have to definitely learn before you attend your INI-CET. Okay. Yes, inhibitors of electron transport chain. Today also I have an MCQ which is related to inhibitors of electron transport chain, using which I will be helping you to memorize all the inhibitors. Okay. So before we start the session, what I would like to tell you all is, in every MCQ, I will not only be telling you the key for the MCQ, I will also be telling you all relevant facts and concepts. Okay. So if you stay with me for the next 1.5 hours, my assurance to you is you would have learned at least 100 facts, minimum 100 facts. Okay. And at least 25 concepts. Okay. So with that assurance, let's start this session. Thank you, Preeti. I'm happy that you're all loving biochemistry. Background fan voice is high. Is that true? Give me a second. Let me switch off the fan. Is it okay, Tetley? Yeah. So this is the first MCQ for today evening. A child presents with mental retardation, a characteristic odor and hypopigmentation. Alongside is provided the result of ferric chloride test that was done in his urine. The cause of the characteristic odor in the patient is. Can you all answer this question? So whenever you're given a case-based MCQ, it can be an image-based or it can be a non-image-based case-based MCQ. There are two steps that you have to follow. Step number one is summarize the history. Do not immediately jump to an answer. Step number one is summarize the history. Step number two is exclude choices. Okay. So let's follow step number one. What are the positive findings here? The positive findings here would be number one, mental retardation. Number two, characteristic odor. Number three, hypopigmentation. And ferric chloride test result is provided to you here. They've given you a control sample and the test sample. Mousy odor, Guthrie's test, phenylketonuria, phenyl acetate. Very good. Excellent. Yes. So what is the right answer? The right answer here is phenyl acetate. I'm happy that many of you are answering it right. So first let me tell you about ferric chloride test. If you take 2 ml of the patient's urine and if you add few drops of ferric chloride solution and if there is a color change to green or black, dark green or black color, then that is positive for ferric chloride. And this ferric chloride test will be positive whenever any ketone body is present in the urine. Okay, so it's actually a non-specific test that will tell you about phenylketonuria. So what is here? The summary is hypopigmentation, mental retardation, characteristic odor and ferric chloride test is positive. So you know the diagnosis is phenylketonuria, which is caused by the defect of phenylalanine hydroxylase. Okay, now let's try to understand, highlight important points. I will do that. Yes. Yes, tyrosine becomes an essential amino acid. You're right. So let me highlight it. Yes, mental retardation is one fact, characteristic odor is the next one, and then hypopigmentation and ferric chloride test is positive. So let's try to understand what to expect in phenylalanine hydroxylase deficiency. The major fate of phenylalanine is that it gets converted to tyrosine in the presence of phenylalanine hydroxylase. And if this does not happen, phenylalanine enters into its minor metabolic pathway. Whenever you're asked what is the fate of any amino acid, you can close your eye and say a transaminase acts on it. So what will be the minor metabolic pathway for phenylalanine? A transaminase acts on phenylalanine. Do you all know that alanine on transamination forms pyruvate? All of you, do you all know that alanine on transamination, thank you Smith Chakrabarti. Do you all know that alanine on transamination forms pyruvate? Yes, right. So phenylalanine on transamination becomes phenylpyruvate. And this is an amino acid which on transamination becomes a keto acid. Because keto acid concentration increases in this condition, you call this condition as phenylketonuria. Pyruvate on reduction becomes lactate. So phenylpyruvate on reduction becomes phenyllactate. Pyruvate on oxidative decarboxylation becomes acetyl-CoA. So phenylpyruvate on oxidative decarboxylation becomes phenyl acetate. Yeah, so these are the minor routes, minor metabolites that you can get from phenylalanine. So tell me what is expected when phenylalanine hydroxylase is deficient or defective. What will not be synthesized? As somebody here told me, yeah, someone was telling me that tyrosine becomes an essential. What? Arun Sharma. Yes, as Arun Sharma has mentioned, tyrosine becomes an essential amino acid. Because there is low tyrosine, what cannot be synthesized? Melanin cannot be synthesized. Without melanin, there will be hypopigmentation. So first manifestation is hypopigmentation. Okay, and because phenylpyruvate accumulates, because it's a ketone body, it answers ferric chloride test. So the second finding is ferric chloride test will be positive. And when these phenyl ketones accumulate in the blood, these phenyl ketones will compete with other neutral amino acids to cross the blood-brain barrier. So brain does not get essential amino acids for its development, and that causes mental retardation. So all of you tell me what is the reason for mental retardation? It's because of the accumulation of phenyl ketones in the circulation, which will not allow neutral amino acids to cross the blood-brain barrier. This phenyl acetate is the reason for mousy odor. Do you all understand this? So tell me what is the reason for mousy odor? Don't get confused with any other metabolites. The major reason for mousy odor, which you see in phenylketonuria, is phenyl acetate. Okay, and if you're asking me, I often get confused about odors that are observed in disorders. Please remember, don't you all know that keyboard and mouse go hand in hand? In your computer, keyboard and mouse go hand in hand, right? So mousy odor is a feature of ketonuria. Do you all understand this? Mousy odor is a feature of ketonuria, and mousy odor is because of phenyl acetate. Okay. So tell me, what is the right answer here? What is the reason for the characteristic odor in this patient? The answer is phenyl acetate. In which condition do you see benzoquinone acetate, all of you? Benzoquinone acetate is a feature of alkaptonuria. So there is another MCQ wherein I will be telling you about all inborn errors of tyrosine metabolic pathway, wherein I will explain about alkaptonuria. For now, alkaptonuria is an inborn error of metabolism caused by the defect of homogentisate oxidase. Very good. Yes, Sneha. So when homogentisate oxidase is defective, homogentisic acid accumulates. That on oxidation forms benzoquinone acetate. It has got nothing to do with phenylketonuria. Where will you see alpha hydroxybutyrate? Alpha hydroxybutyrate is a feature of methionine malabsorption. So I have a request for all of you. Please watch the YouTube session on PrepLadder YouTube channel. I've done another session which is NEET PG MCQ. Yeah, targeting NEET PG, we did a series, right? So in that, I've discussed few inborn errors of metabolism. Please watch both these sessions, okay? So alpha hydroxybutyrate is because of what? Where do you see alpha hydroxybutyrate? In methionine malabsorption syndrome, okay? So let's discuss the next MCQ. This is an interesting MCQ. All of you have a look at it. A 65-year-old man with alcohol use disorder presented with insomnia, irritability and confusion. Have you? Yes, Westhouse syndrome. Arun Sharma is rocking it. Very good. So tell me, what is the diagnosis? His son attributed the confusion to a probable dehydration caused by diarrhea. On examination, there were erythematous non-itchy skin lesions in the sun-exposed areas. Do you see that here? Yeah, in the sun-exposed areas, a person is presented with red, non-itchy. Yes, what is answer? Some of you are answering it as C, some of you are answering it as D, pellagra. Excellent. Very good. Yes, pellagra is the right answer. Okay, so don't you know that pellagra is characterized by 3 Ds? What are the 3 Ds? Diarrhea, dermatitis and dementia. Don't you see all the 3 Ds here? What are the 3 Ds that you observe here? Let me highlight it. The first D is diarrhea, right? And then you see dermatitis, erythematous non-itchy skin lesions in the sun-exposed areas. So diarrhea, dermatitis, dementia, there is confusion. So this is 3 Ds of pellagra. The most cliche question. Okay. And so 3 Ds of pellagra, if you're asking me, is an alcoholic prone to develop pellagra? Is a chronic alcoholic is prone to develop every essential micronutrient deficiency, not only thiamine deficiency. Just because all textbooks talk to you about thiamine deficiency, don't think that a chronic alcoholic is susceptible to only develop thiamine deficiency. They are prone to develop all vitamin deficiency. So they are prone to develop niacin deficiency or pellagra as well. So before we end this, yeah, I will share it. Delirium and depression. Yes. So let's discuss this. Before we end this MCQ discussion, using this MCQ, let me help you understand about other choices as well. So tell me about choice A, Wernicke's encephalopathy. What is Wernicke's encephalopathy? This is acute thiamine deficiency. Yeah, acute thiamine deficiency, which is characterized by GOVA. Can you tell me what is GOVA? G stands for global confusion. O stands for ophthalmoplegia. All of you listen to this. I will share the PDF. I will share the annotated PDF on the PrepLadder Telegram channel. Okay, so don't waste your time writing down anything. Please use the session to understand concepts and memorize facts, so that by the end of the session, you should have learned about all these MCQs. Later on, you should only revise. Okay, so don't waste your time writing it down. So global confusion, ophthalmoplegia and ataxia. These 3 are the features of Wernicke's encephalopathy, acute thiamine deficiency. And do you think this fits into a diagnosis of Wernicke's encephalopathy? No, because Wernicke's encephalopathy does not present with diarrhea. It has got nothing to do with dermatitis, right? No diarrhea, no dermatitis. That is why it's not Wernicke's encephalopathy. What is delirium tremens? Delirium tremens is a part of alcohol withdrawal syndrome. And there's no history of alcohol withdrawal here, right? Do you see any history of alcohol withdrawal here? No. And delirium tremens is observed between 2nd and the 10th day of alcohol withdrawal, and it presents with what are the manifestations of yes, exactly. Yeah, I will tell you, Piyush, about Korsakoff syndrome. Yeah, between 2nd and the 10th day of alcohol withdrawal. And what does it present with? I have a mnemonic for delirium tremens. It is GHN. Yeah, I remember it is Government Hospital Nurse, GHN. What does GHN stand for here? Global confusion, hallucination, nightmares. It's characterized by global confusion, hallucination, nightmares. But they also present with physical manifestations because of autonomic hyperactivity. Because of autonomic hyperactivity, they present with increase in blood pressure, they present with increase in heart rate, increase in body temperature, tremors. That is why the name delirium tremens. So because it's characterized by autonomic hyperactivity, they also present with high body temperature, high heart rate, high blood pressure and tremors. And this is not delirium tremens because there is no history of alcohol withdrawal, and delirium tremens has got nothing to do with diarrhea, nothing to do with dermatitis. Okay, and what is Korsakoff syndrome? As Piyush has answered it, in Wernicke's encephalopathy, please understand this, both in Wernicke's encephalopathy and in Korsakoff syndrome, mammillary body gets affected. And when mammillary body gets affected, initially there is just a confusion. That is why Wernicke's encephalopathy is characterized by global confusion. Whereas in Korsakoff, mammillary body is completely out. It has undergone atrophy. So Papa circuit does not work. So the person will not be able to recollect any information. So the person presents with retrograde amnesia, anterograde amnesia. Chronic thiamine deficiency or Korsakoff syndrome will present with retrograde amnesia, anterograde amnesia. Because of memory loss, to fill up the gap, the person will start building stories. Yeah, the person will start fabricating stories. That is called as confabulation. Okay, confabulation and sensory agnosia. So these are the features of Korsakoff syndrome. Is there any major difference in your regular videos from Speed App? Yeah, there are major differences, Vaibhav. In Speed App, you won't be seeing so many clinical case-based MCQs, so many image-based MCQs. You won't see ABG report interpretation. Yeah, there are so many differences. Okay. So that's about Korsakoff syndrome. Okay, and so what is the answer here? The answer here is pellagra, which is characterized by 3 Ds. 3 Ds will include diarrhea, dermatitis and dementia. So how many of you remember seeing this MCQ in any of the question papers? Yeah, almost a similar image. What is the right answer, all of you? The right answer is, so what is the diagnosis here? What is your finding? What is the cutaneous finding here? It is called as phrenoderma. And what is phrenoderma? Phrenoderma is nothing but follicular hyperkeratosis. Do you all understand this? What is phrenoderma? It's nothing but follicular hyperkeratosis. And do you see small papular lesions here with keratin plug in the tip? Yeah, those white tiny spots in the tip, they are called as keratin plug. So when you see keratin plug in the tip of papular lesions, then you should call it as follicular hyperkeratosis or phrenoderma, which is caused by vitamin A deficiency or essential fatty acid deficiency. Yeah, vitamin A or essential fatty acid deficiency. So we know that far. Okay, but the question is even more tricky because they have given you 3 forms of vitamin A. Arun Sharma says it's the aldehyde form. Acrodermatitis entropathica, how to differentiate? Okay, so if it's acrodermatitis entropathica, it will be in the acral region, oral, perioral region or perianal region. So that is why it's acrodermatitis. And it's also characterized by diarrhea. Here, where do you see? You see this in the extensor surfaces. These small papular lesions are seen on the extensor surfaces of your limb with keratin plug. Did you see this? Keratinous plug localized to elbows. That is why this is phrenoderma. Okay. Yes, perioral or perianal. So many of you are answering it as the aldehyde form retinal. Please remember the aldehyde form. Here do you see retina? Yeah, here do you see retina? So this retinal or the aldehyde form is seen in rods and cones. That is the one that is present in eye. It is present in rods and cones in rhodopsin and conopsin. That has got nothing to do with skin lesions. So which deficiency causes skin lesions? It is retinoic acid. What is the right answer? Very good, Akhtar. The answer is retinoic acid, choice C. So I'm going to now tell you about the 3 vitamin A forms. What are the 3 vitamin A forms? The alcohol form retinol, the aldehyde form retinal, and the acid form, which is retinoic acid. And they often ask you questions related to the 3 forms of vitamin A. First, about the alcohol form. This is the form in which vitamin A is absorbed. This is the form in which vitamin A is transported in the blood. This is the form in which vitamin A is stored. So tell me, what is the significance of the alcohol form? Vitamin A is absorbed, transported and stored in the form of retinol, the alcohol form. Now retinal is the one which is present in eye. To remember that, what did I ask you to remember? Retina. That tells you it has got something to do with eye. So in eye, it is present in rods and cones. How is it present in rods and cones? In the form of rhodopsin or conopsin. So what is rhodopsin or conopsin? Until stimulated by light, rhodopsin is Levensis retinal in the center. What is it? It is Levensis retinal in the center that is surrounded by opsin. Okay, so that is the significance of retinal. And then retinoic acid. What about retinoic acid? There are 2 forms of retinoic acid. One is all-trans retinoic acid. The other one is 13-cis retinoic acid. And all-trans retinoic acid helps in growth and differentiation of cells. Yeah, it helps in just growth and differentiation of cells. Whereas 13-cis retinoic acid suppresses keratinization of epithelium. Do you all understand this? What is the significance of 13-cis retinoic acid? It suppresses keratinization of epithelium. That is why what happens in vitamin A deficiency, when there is low 13-cis retinoic acid, there is no suppression of keratinization. There is excess keratinization that causes keratin plug to be formed. And that is the reason for follicular hyperkeratosis of phrenoderma. For the same reason, when conjunctiva undergoes keratinization, that causes conjunctival xerosis. And the excess keratin in the eye will accumulate as Bitot spots. So tell me, what is Bitot spots, all of you? Bitot spot is nothing but keratin accumulation. Okay, there is nothing but keratin debris is what we call it as. Okay, so everything is because of keratinization of epithelium. Okay, so what is the right answer here? The right answer here is retinoic acid. Yes, it is used in M3-AML. Very good. Retinol is what is supplemented. Tithir surai. Okay. Yeah, Bitot spot is X1b. Very good. So can I wait for you to answer? A 15-year-old boy, you don't have to worry about these choices, okay? Because it's an INI-CET based session. I thought I should ask you concepts about the disorder, okay? But otherwise, just make a diagnosis first. A 15-year-old boy presented to the ophthalmology department with an acute reduction in the visual acuity in both the eyes. The direct observation of both the eyes is shown here. What is that you see here? Yeah, what is that you see here? Do you see supratemporal dislocation of the lens? Yeah, supratemporal dislocation of the lens. What is it? It is Marfan syndrome. Very good, Arun Sharma. It is Marfan syndrome. The ophthalmologist suspected a disorder and ordered for genetic testing which released fibrillin 1 gene mutation. So exactly like what you suspected, fibrillin 1 gene mutation is the diagnosis, which is nothing but Marfan syndrome. Which of the following is true about the disorder? Excellent. Very good, Rakesh. Very good, Siddhant. Very good, Sahil. Yes. So which of the following is true about the disorder and the protein involved? The protein reduces TGF-beta levels. Fibrillin 1 reduces TGF-beta levels is true. Alpha-2 agonist. Do you give alpha-2 agonist or do you give beta blockers, all of you? We give beta blockers and losartan. To delay the progression of the disorder, we give beta blockers and losartan to a patient with Marfan syndrome. So B is false. Is it an autosomal recessive disorder? No, it is an autosomal dominant disorder. The protein involved reduces the elasticity of tissues normally. Until there is normal fibrillin, it increases the elasticity. It supports the elasticity of tissues. So B, C and D are false. So what is the right answer, all of you? Very good, Ian Donald. So the right answer is the protein reduces TGF-beta levels. This you should know. Only then you will understand why a patient with Marfan syndrome can present with aortic dissection. Do you all know that? Yeah, why are you worried about a patient suffering from Marfan syndrome? Because they can present with aortic dissection. And the reason for aortic dissection is normally fibrillin 1 suppresses TGF-beta levels. When it is mutated, there is increase in TGF-beta level and that causes necrosis, cystic medial necrosis, that causes dissection. And only to reduce TGF-beta levels externally, because the body is not able to reduce TGF-beta levels. To reduce it externally, you give beta blockers and losartan. Do you all understand this? Yes, prevents aortic dissection. Good evening, Akshay. Okay, so I'm going to tell you all about this condition. So what is the summary here? The summary is a patient or a boy presenting with spontaneous bilateral superotemporal dislocation of the lens. That is the observation. And the most common cause of spontaneous bilateral superotemporal dislocation of the lens would be Marfan syndrome. And reciprocally, Marfan syndrome most commonly presents as bilateral superotemporal dislocation of the lens. Okay. Now, what are the facts that you need to know about Marfan syndrome? It is an autosomal dominant disorder. It is caused by the mutation of FBN1 gene of chromosome 15. Mutation of FBN1 gene of chromosome 15. And what is the role of this FBN1 gene? It codes for fibrillin protein. And fibrillin protein is responsible for forming microfibrils in connective tissue. And these microfibrils can either be associated with elastin or they might not be associated with elastin. And whenever they are associated with elastin, they support the elasticity of tissues. Do you all understand this? They support the elasticity of tissues. And without elastin, when they exist, they improve the tensile strength. Okay. An example for tissues wherein they support elasticity would include number 1, skin. Yeah, starting from skin, lungs and blood vessels. So in skin, blood vessels and lung, what is the role of fibrillin? It supports elasticity. Without elastin, it helps in supporting the tensile strength. Inframedial or infranasal, yes, that is homocystinuria. Yes, Prader-Willi is also, you're right. So without elastin, it increases tensile strength, and this is the form that is present in tendons. This is the type of fibrillin that is present in tendons and in suspensory ligaments of limb. And apart from these two functions, the function of fibrillin is that it suppresses TGF-beta release. Okay, what does TGF-beta normally do? It supports necrosis. Normally, TGF-beta causes necrosis. Now tell me what will happen when FBN1 gene is mutated and there is no fibrillin that is produced. So what will be lost? There will be loss of elasticity. When skin loses elasticity, that is what you see as when you stretch the skin does not come back to its original position. Yeah, that is what you see, right? Usually Marfan syndrome patients, they present with loss of elasticity of the skin. And in lung, when the person inhales, the lung expands. And the moment the person stops inspiring, the elastic recoiling of lung should bring it back to the original position that causes passive exhalation. Because there is no elasticity, what will happen? There will be bulle formation, keeps expanding. So that causes bulle formation and that can present with pneumothorax. And because blood vessels expand but they don't come back to their original position, valves expand and that causes aortic regurgitation, mitral valve prolapse. Right? Aortic regurgitation, mitral valve prolapse. And I told you it suppresses TGF-beta levels. Now there is no suppression of TGF-beta, there is necrosis. That causes cystic medial necrosis and that causes aortic dissection. And when there is no tensile strength in tendons, that causes arachnodactyly. Yeah, that causes arachnodactyly. And when suspensory ligament of limb become weaker, that causes superotemporal dislocation of the lens. So have you been able to explain every feature here? All of you? Have you been able to explain every feature here? Now do you understand that biochemistry is essential? Yeah, for you to understand every clinical subject. It's just based on what fibrin does. Okay. So what are the manifestations of Marfan syndrome? Marfan syndrome will present with bullae pneumothorax. It presents with aortic regurgitation, mitral valve prolapse. It presents with dissection of aorta. Can you tell me what is the major reason for aortic dissection? It is because there is increase in TGF beta levels which causes cystic medial necrosis. And it causes arachnodactyly, it causes superotemporal dislocation of the lens. Okay. And this is why what is that we give? We give beta blockers and losartan to avoid progression of the disorder, to avoid a person presenting with aortic dissection. So if this causes superotemporal dislocation, what causes infranasal dislocation? Infranasal dislocation of the lens is caused by homocystinuria. So can we discuss the differences between homocystinuria and Marfan syndrome? Yeah, always compare and contrast between similar conditions. Always have tabular columns in your notes. Okay. I hope that you all have the habit of noting down important facts and concepts as and when you learn. So your notes should be full of comparing and contrasting two similar features, two similar disorders, two similar numbers. Okay. So what are the differences between Marfan syndrome and homocystinuria? The first difference is based on inheritance. As you all know, Marfan syndrome is autosomal dominant. Very good, Ian Donald. Whereas homocystinuria is autosomal recessive. Which is the gene that is mutated in Marfan syndrome? That is FBN1 gene. FBN1 gene of chromosome 15. Whereas homocystinuria is caused by the defect of type 1 homocystinuria is caused by the defect of cystathionin beta synthase in chromosome 21. Okay, type 1 homocystinuria is caused by the defect of cystathionin beta synthase of chromosome 21. Lens dislocation, Marfan syndrome is, just now I told you, superotemporal dislocation, whereas in homocystinuria it is infranasal dislocation of the lens. Joints in Marfan syndrome, just now I told you, right? Because tendons are weak, joints become hypermobile. So what will you see in Marfan syndrome? Hypermobile joints, whereas there is a joint restriction, restrictive movements in homocystinuria. Okay, blood vessels, what will you see? Because the elasticity of the blood vessel is lost, they are dilated. So blood vessels in Marfan syndrome will be dilated, whereas in homocystinuria, what you would see is a vaso-occlusive disorder. When will you suspect homocystinuria? Whenever a patient presents with accelerated atherosclerosis, or whenever a patient presents with accelerated thrombosis. Example, young patient presenting with MI, or a young patient presenting with stroke. What will you think of? You should think of homocystinuria. If you're asking me why does homocystinuria present with accelerated atherosclerosis and accelerated thrombosis, it is because homocysteine activates Hagman factor. Yeah, it activates Hagman factor, so clotting pathway gets stimulated. That is why accelerated thrombosis. And homocysteine modifies LDL particle. Such modified LDL particles are more prone to cause atherosclerosis. That is why they present with accelerated atherosclerosis and accelerated thrombosis. So homocystinuria will present as vaso-occlusive disorder, whereas Marfan syndrome will present with vasodilatation. Treatment, what will you give for treating Marfan syndrome? Just now I told you for Marfan syndrome it is beta blockers and losartan. Whereas homocystinuria, depending upon the type, you can treat the patient. If it is type 1 homocystinuria, if it's type 1 homocystinuria, the patient will respond to pyridoxal phosphate supplementation. If it is type 2 homocystinuria, they respond to B12 and folate supplementation. Got it? Yeah, so that's about differences between Marfan syndrome and homocystinuria. So what is the take-home message for all of you? The take-home message is superotemporal dislocation of lens for Marfans, infranasal dislocation for homocystinuria. And Marfan syndrome is autosomal dominant, homocystinuria is autosomal recessive. And please remember, cystic medial necrosis, the reason for aortic dissection. The reason for this necrosis is fibrillin 1 gene suppresses fibrillin 1 protein suppresses TGF beta release. In the absence of fibrillin 1 protein, there is increased TGF beta that causes cystic medial necrosis. Okay. Yeah, very good. In homocystinuria, you can also see mental retardation. You're right. So tell me, what is the right answer? The right answer is the protein reduces TGF beta levels. Is that true? Yes, it is true. Alpha 2 agonist is false. Beta blockers. Okay. Please elaborate why B6 deficiency causes homocystinuria. Okay. I can explain that. How many of you want to know about it? How many of you want to know about homocysteine pathway? If there are many, I will explain. Okay, even otherwise, let me explain. So homocystinuria, homocysteine has got two fates. Nobody wants to know? No need. Okay, I'll quickly tell you. Okay, I'll quickly tell you because there is somebody who has asked. Just 2 minutes, I'll finish this, okay? PDFs, Anat and Physio, we didn't get. Will you share? I will share, Preeti. I will share it for sure. They have not stopped. I will remind them, okay? Okay, so homocysteine has got two fates. One is homocysteine can become cysteine or homocysteine can become methionine. How does homocysteine become cysteine? In the presence of cystathionin beta synthase. In the presence of cystathionin beta synthase, homocysteine becomes cysteine. And that cystathionin beta synthase is dependent on B6. Yes, I have a Telegram group. You can search for me with my name, C. Shanmugapriya. Okay. So B6, vitamin B6 is necessary for cystathionin beta synthase, which converts homocysteine to cysteine. And how do you convert homocysteine to methionine? That is done by methionine synthase. So what does methionine synthase do? As the name indicates, methionine synthase converts homocysteine to methionine. And this methionine synthase is dependent on methyl B12. This enzyme is dependent on methyl B12. This methyl B12 gets its methyl group from methyl tetrahydrofolate. Okay. And a defect of cystathionin beta synthase causes type 1 homocystinuria, which responds to B6 administration. A defect of methionine synthase causes type 2 homocystinuria, and this type 2 homocystinuria will respond to B12 and folate administration. Clear? Is it clear? Who asked it? Tihira. I forgot the name. Yeah. Titir. Have you understood it? Okay. So I'm going to explain this MCQ now. This one. An infant presented with watering of the eye, incessant cry, and on observation, tiny erosions were seen as shown in the image. Okay. So what you see here is a spontaneous corneal erosion. The pediatrician also observed a rough palm in the infant. Yeah, there is rough palm in the infant. The probable diagnosis is, what do you think is the right answer? Some of you are answering it as type 2, some of you are answering it as type 3. I'm happy that yeah. So what is the right answer here? The right answer here is type 2 tyrosinemia. Yeah, it is type 2 tyrosinemia. If you're asking me how to remember this, will you call this condition as oculocutaneous syndrome? All of you? Can you call this condition as oculo? Because you see an eye condition and there is a skin condition. So what are you going to call it as? You're going to call it as oculocutaneous syndrome. And how many eyes do we all have? We have 2 eyes. So oculocutaneous syndrome is caused by type 2 tyrosinemia. What is it? This is type 2 tyrosinemia. And this type 2 tyrosinemia is caused by the defect of 2 T's. What are the two T's? Tyrosine transaminase. So this is how you can memorize this condition. So what is this condition? What is the diagnosis? Oculocutaneous syndrome. We have two eyes, so it is type 2 tyrosinemia. Type 2 tyrosinemia is caused by the defect of two T's. What do those two T's stand for? Tyrosine transaminase deficiency. Okay. Yes, so now I'm going to help you understand about all tyrosinemias, type 1 tyrosinemia, type 2 tyrosinemia, type 3 and alkaptonuria, okay? And I'm not going to just bombard you with facts here. I'm going to help you understand about how tyrosine normally gets metabolized. Then you will understand what happens when these enzymes become defective. You'll not forget this in your exam, okay? Can we do that? Yes. So how is tyrosine metabolized? What did I tell you? Whenever I ask you how is an amino acid metabolized, you should say a transaminase acts on it. So how will tyrosine be metabolized? Tyrosine is also acted upon by a transaminase. Tyrosinase deficiency causes albinism. Very good. Yes. So how is tyrosine metabolized? What is the first enzyme? The first enzyme, as always, would be a transaminase. So here it is tyrosine transaminase. Will you allow me to call tyrosine as hydroxyphenylalanine? Yeah, can you call tyrosine as hydroxyphenylalanine? Yes. So phenylalanine on transamination forms phenyl pyruvate. So hydroxyphenylalanine on transamination will form hydroxyphenyl pyruvate. So tell me, what is the product you get when tyrosine transaminase acts on tyrosine? You get para-hydroxyphenyl pyruvate. The next enzyme is para-hydroxyphenyl pyruvate dioxygenase. Logical name, right? If you have para-hydroxyphenyl pyruvate, the next enzyme has to be para-hydroxyphenyl pyruvate dioxygenase, which forms homogentisic acid. What logically will be the next enzyme? If you have homogentisic acid, the next enzyme has to be homogentisate oxidase. And this homogentisate oxidase converts homogentisic acid to mallyl acetoacetate. Because I am hiding it, I am writing it here. What is the product that you get? You get mallyl acetoacetate. Then cis-trans isomerase acts on mallyl acetoacetate, converts it into fumaryl acetoacetate. And all that you will have to do is you have to cleave this. Okay. For cleaving this, the enzyme that you want is fumaryl acetoacetate hydrolase. So the last enzyme is fumaryl acetoacetate hydrolase, which cleaves fumaryl acetoacetate to form fumarate and acetoacetate. So what are the final products that you get from tyrosine? You get fumarate and acetoacetate. Is that clear? So this is normal tyrosine metabolism. Let's learn about disorders. Okay. So let's start with type 1 tyrosinemia. Whenever I ask type 1 tyrosinemia is caused by what? Many students would answer it as a defect of tyrosine transaminase. Now you know that is not the case. Because what did I tell you? Tyrosine transaminase defect. Two T's. Defect will cause type 2 tyrosinemia. So type 1 tyrosinemia paradoxically is caused by the defect of the last enzyme. So which enzyme defect causes type 1 tyrosinemia, all of you? Fumaryl acetoacetate hydrolase defect. So all of you answer it along with me. Type 1 tyrosinemia is caused by the defect of which enzyme? Fumaryl acetoacetate hydrolase. And this condition is called as hepatorenal syndrome. What do you call it as? You call it as hepatorenal syndrome. The reason is the precursor. What is a precursor which accumulates in this condition? It is fumaryl acetoacetate. That gets converted to succinyl acetone. And this succinyl acetone is toxic to liver and renal parenchymal cells. When it damages liver parenchymal cells, it causes jaundice. Many a times type 1 tyrosinemic children will be misdiagnosed as hepatitis. They will be treated as infective hepatitis. So initially it will present as jaundice, hepatomegaly, but it progresses to liver cirrhosis and even hepatocellular carcinoma. So if the history says a 10-year-old boy presenting with a massive elevation of AFP, yeah, a 10-year-old boy presenting with a massive elevation of AFP, what should you suspect? You should suspect type 1 tyrosinemia. Okay, and because the same succinyl acetone is also toxic to renal parenchymal cells, when kidney gets damaged, that causes Fanconi syndrome. What does it cause? It causes Fanconi syndrome and chronic kidney disease. Okay, and additionally, the succinyl acetone inhibits delta ALA dehydratase. What will happen when you inhibit delta ALA dehydratase? Delta ALA accumulates and that causes porphyria. So many a times type 1 tyrosinemia patient will be misdiagnosed. Type 1 tyrosinemia patient will be misdiagnosed as infective hepatitis patient or as hepatocellular, primary hepatocellular carcinoma patient or as porphyria for this reason. Okay, and also in the MCQ, yeah, whenever you're given a case-based MCQ, if you see a term succinyl acetone, close your eye and answer it as type 1 tyrosinemia. So type 1 tyrosinemia, pathognomonic feature is succinyl acetone peak. Yeah, what is it? Succinyl acetone peak is pathognomonic for type 1 tyrosinemia. Are you clear about type 1 tyrosinemia now? So what is type 1 tyrosinemia due to? Because of the defect of the last enzyme. This repetition is for your benefit. Please repeat it along with me. In every session, I would be telling you this. There is no secret. There is no shortcut to memory. Will you all agree with me? There is no secret. There is no shortcut to memory. It's just repetition that you need to do. Okay. So type 1 tyrosinemia is caused by the defect of what? It's caused by the defect of the last enzyme. Which enzyme? Fumaryl acetoacetate hydrolase. It's called as hepatorenal syndrome. Just the name will tell you its manifestations. Jaundice, hepatomegaly, cirrhosis, hepatocellular carcinoma. Fanconi syndrome, chronic kidney disease. Because it inhibits delta ALA dehydratase, it mimics porphyria. Okay, succinyl acetone is a pathognomonic feature. Now let's learn about type 2 tyrosinemia, about which we have already learnt. Tell me, type 2 tyrosinemia is caused by the defect of which enzyme? Tyrosine transaminase. So tyrosine transaminase defect causes type 2 tyrosinemia. What are the manifestations? 2 eyes. So the manifestation would be oculocutaneous syndrome. Why is it called as oculocutaneous syndrome? Because it presents as painful corneal erosions. What does it present as? Painful corneal erosions and palmar hyperkeratosis. Yeah, what do you mean by palmar hyperkeratosis? For a child, the palm will be rough-skinned. Okay, so painful corneal erosion and palmar hyperkeratosis will be type 2 tyrosinemia. This type 2 tyrosinemia is otherwise called as Richner-Hanhart syndrome. Okay, type 2 tyrosinemia is also called as Richner-Hanhart syndrome. Okay, so please discuss lot of topics. Okay, so that's about type 2 tyrosinemia. Okay, now about type 3 tyrosinemia is caused by the defect of para-hydroxyphenylpyruvate dioxygenase. What is a good source to clear the basics of biochemistry? Please watch PrepLadder regular videos. Okay, so it has been uploaded already. You can watch PrepLadder biochemistry videos, regular videos. I have explained everything from the very basic till the complex concept. I have also included ABG report interpretation. I have included all clinical case-based MCQ discussion. Okay. Yeah. So that's about type 2 tyrosinemia. Now type 3 tyrosinemia is caused by the defect of para-hydroxyphenylpyruvate dioxygenase. So please remember, para-hydroxyphenylpyruvate dioxygenase defect can cause 2 disorders. One is low activity causes type 3 tyrosinemia. Gain of function mutation. Okay, gain of function mutation causes Hawkinsinuria. Preeti, I'm not repeating it because I'm not repeating it because you will forget it. I am repeating it so that you will be able to memorize it before you leave the session. Okay. So after the session, it should be just repetition. When you will have to just recollect all the facts. Okay. So hang on with me. You will never regret. So type 3 tyrosinemia is caused by the low activity of para-hydroxyphenylpyruvate dioxygenase. Gain of function mutation causes Hawkinsinuria. Okay, and type 3 tyrosinemia is characterized by intermittent ataxia. It is characterized by intermittent ataxia and seizures. Okay. Hawkinsonuria will be characterized by metabolic acidosis. It is characterized by metabolic acidosis and with swimming pool odor. Yeah, swimming pool odor of urine is a feature of Hawkinsonuria. So if you watch the session which I conducted for NEET PG, I have shown you many images to memorize about odor. I have shown you an image wherein a hawk is flying above the pool. So Hawkinsonuria is characterized by swimming pool odor of urine or chlorine odor of urine. Okay. So that's about para-hydroxyphenyl pyruvate dioxygenase defect. Now homogenticate oxidase defect causes alkaptonuria. And you cannot attend any of your exams if you have not learnt about alkaptonuria, because that frequently this is being asked about. The reason is it's quite common in India. Okay, so when homogenticate oxidase is defective, homogentisic acid accumulates. And this homogentisic acid undergoes oxidation to form benzoquinone acetate. Let me use the next slide to write about alkaptonuria. So alkaptonuria is an inborn error of metabolism caused by the defect of homogenticate oxidase. When homogenticate oxidase is defective, the precursor homogentisic acid accumulates. That undergoes oxidation to form benzoquinone acetate. Yes, high anion gap metabolic acidosis. You're right, Titir Surai. It causes high anion gap metabolic acidosis. Okay, so it undergoes oxidation to form benzoquinone acetate, and this benzoquinone acetate undergoes polymerization to form melanin-like fibrils. And this melanin-like fibril accumulation in the cartilage causes cartilage destruction, and that is responsible for euchronosis. So what will the patient with alkaptonuria present with? The patient will present with multiple intervertebral disc bulges or prolapses, multiple joints involvement. They complain of knee pain, elbow pain, ankle pain. And that's called as euchronosis. That's because of accumulation of melanin-like fibrils in the cartilage leading on to cartilage destruction. And accumulation of melanin-like fibril in the skin is the reason for pigmentation of the pinna. What will you see? You will see pigmentation of the pinna, tip of the nose. Thenar and hypothenar eminences will also be pigmented. And the same melanin-like fibril also accumulates in mucous membrane. Okay, and that is responsible for Osler sign. All of you please remember, the first sign of alkaptonuria is Osler sign. What is Osler sign? Black pigmentation of sclera along the line of attachment of both medial and lateral rectus. So the first sign of alkaptonuria is Osler sign, which is caused by melanin-like pigment accumulation in the mucous membrane. Okay, and the same melanin-like pigment accumulation in the urine is the reason for urine turning dark on standing. That is why the name alkaptonuria. Alkapton means black. Alkaptonuria is black urine disease wherein urine turns dark on standing. And that will be the first symptom of alkaptonuria. I hope you all know that symptom is something which the patient comes and tells you. Sign is something which you elicit. So the first symptom will be urine turning dark on standing. First sign will be Osler sign for alkaptonuria. Okay? Yeah. So what is the right answer here? The right answer here is type 2 tyrosinemia, which is oculocutaneous syndrome. So this is the next MCQ. You're asking me, we would watch. Okay, thank you, Pisces. Lipoprotein electrophoresis of a patient. You have already given me the right answer. Many of you are answering it as B. Okay, for the previous question. Okay. So lipoprotein electrophoresis of a patient presenting with chronic kidney disease, corneal opacity, low HDL. So low HDL is hypo-alpha lipoproteinemia, right? Low HDL is hypo-alpha lipoproteinemia. The patient is also presenting with chronic kidney disease and corneal opacity. The band identified as A. They are asking you what is this A due to? Chylomicron. Very good, Titir Surai. Yes. So corneal opacity. Can you call somebody with corneal opacity to suffer from fish eye disease? Can you call that disease as fish eye? Corneal opacity is called as fish eye disease. What is the favorite food of cat? Favorite food of cat is fish, right? So fish eye disease is caused by what? Cat, LCAT deficiency. Do you all understand this? So as far as LCAT deficiency is concerned, there are two defects. One is partial defect. The other one is, yes, discoidal HDL. Very good, Arun Sharma. So LCAT deficiency, there are two types of LCAT deficiency. One is partial LCAT deficiency. The other one is complete LCAT deficiency. Partial LCAT deficiency will present with only corneal opacity, which you call as fish eye disease. Complete LCAT deficiency will also present with corneal opacity, but along with that, what you would also see is chronic kidney disease. Okay, so let me tell you what to expect. Transportation of, yeah, you're right, you're all right. So can we learn about lipoprotein electrophoresis now? Yeah, so I will first tell you about lipoprotein electrophoresis, and then I will tell you what to expect in LCAT deficiency. Okay, so how is lipoprotein? If you're not a big fan of what I'm doing, I'm very sorry, Preeti. I will try to do my best. Okay, so type 3, so let me tell you about lipoprotein electrophoresis. Usually lipoprotein electrophoresis is run on a glass slide. Okay, so on this glass slide, we apply a support medium, which is most commonly agarose. Okay, and towards one end of the glass slide, you apply the serum or plasma, lipoprotein of which has to be separated using lipoprotein electrophoresis. So towards one end of the glass slide, you apply the serum or plasma, lipoprotein of which is going to be separated. Okay, and then you place this glass slide on an electrophoretic tank, and you fill up this electrophoretic tank with an alkaline buffer. Yeah, you fill it with an alkaline buffer of pH 8.6. So what will happen when you drop? Thank you, Kamal. Yeah, thanks, oxytocin. Thank you, all of you. So the purpose of you adding an alkaline buffer is, once these lipoproteins sense the alkaline pH, they try to neutralize the alkaline pH. To neutralize the alkaline pH, they give off their H+. And once they give off their H+, they all become negatively charged. So the purpose of adding an alkaline pH is, thank you all of you. I'm very happy that all of you are supporting me. Yes, Preeti, I understand what you're trying to say. The PDFs, I mean, only because I cannot have an animation here. Yeah, because we are using an app, there's going to be no animation. So I cannot be just showing you everything and then telling you what is there on the slide. So I would like it to be animated. That is why it might look as if it's 158 slides. But if you look at it and read it, it will be a concise one. Okay, so for every topic, there will be a concise slide. Read that slide alone, it will tell you all the facts and concepts. Okay. Yeah, so the point behind you adding an alkaline buffer is to give all these lipoproteins negative charges. Once you're done with giving negative charges to all these lipoproteins, you connect this tank to an electrical supply. Close to the point of application is connected to a negatively charged electrode. The opposite side is connected to a positively charged electrode. Can you see that here? Close to the point of application is connected to a negatively charged electrode. The opposite side is connected to a positively charged electrode. So when you switch on the electric current, because all these lipoproteins are negatively charged, they start moving towards the oppositely charged electrode. The migration here is affected by two factors. Just two factors will determine the mobility. The first factor is number of negative charges. Yeah, the first factor is number of negative charges. The second factor is the size. More the number of negative charges, rapidly will the lipoprotein move towards the oppositely charged electrode. So the lipoprotein which moves the fastest and is present at the farthest point from the point of application will be called as the alpha band. The last band which is present here, farthest from the point of application, is called as an alpha band, and this alpha band has got HDL. Why do you think HDL moves the fastest? For two reasons. Because HDL has got the highest phospholipid content. It has got the highest protein content. Do you understand this? So if you ask which lipoprotein has got the highest phospholipid and the highest protein content, that can be a one-liner. Your answer should be HDL, and that is why HDL moves the fastest, present farthest from the point of application. In quite contrast to this, chylomicron size being larger, the largest lipoprotein is chylomicron, and because its size is the largest, it cannot move at all, and it is present at the point of application. So if you see a band at the point of application, that is chylomicron band. Okay, usually you don't see a chylomicron band because you're supposed to run a fasting sample for lipoprotein electrophoresis. And I hope you all remember that chylomicron is a product of dietary triacyl glycerol. So when you run a fasting sample of a normal individual, you will not see a band at the point of application. But if you see a band at the point of application, then you should suspect lipoprotein X. Yeah, when you run a fasting sample, if you see a band at the point of application, what is it? It is going to be lipoprotein X. And lipoprotein X and C, don't they look similar? X and C look similar. So lipoprotein X is caused by LCAT deficiency. Okay, what is the function of LCAT? LCAT or lecithin cholesterol acyl transferase helps in the conversion of discoidal HDL to spheroidal HDL. Do you all understand this? LCAT, what is its role? It helps in the conversion of discoidal HDL to spheroidal HDL. So whenever there is LCAT deficiency, which HDL would accumulate? Discoidal HDL would accumulate. And that discoidal HDL takes a shape which is lamellar, and that is called as lipoprotein X. So lipoprotein X is a feature of LCAT deficiency. It's also a feature of obstructive jaundice. Because whenever there is an obstruction of the biliary tract, very good, very good Asra. So it's also a feature of obstructive jaundice because whenever there is an obstruction of the biliary tract, the bile salt will overflow from the bile duct into the circulation. And once bile salts enter into the circulation, because they are amphipathic, they also take a shape which resembles lipoprotein X. So tell me, what are the possibilities if you see a band at the point of application, that is lipoprotein X, which is because of LCAT deficiency or because of obstructive jaundice. Okay, and next to the chylomicron band is the beta band. And this beta band has got LDL. Do you understand this? Beta band has got LDL. And the next band which moves ahead of beta band is called as pre-beta band. Why do you call it as pre-beta band? Because it moves ahead of beta band, and this pre-beta band has got VLDL. Okay, so in a normal person's lipoprotein electrophoresis, usually how many bands do you see? Normal person's lipoprotein electrophoresis, you see 3 bands. What are the 3 bands? The alpha band is HDL, beta band is LDL. Between alpha and beta, you have a pre-beta band which is VLDL. Normal lipoprotein electrophoresis, you don't see remnants at all because remnant concentration is too low. Okay, but if at all remnants are present, they will be present somewhere here, close to the beta band. Can you see a gray band here? If at all remnants are present, these remnants are expected to be there in the beta region, close to the beta band, but usually you don't see remnant to form a band. But what happens in type 3 hyperlipoproteinemia? Very good, Arun Sharma. Type 3 hyperlipoproteinemia is caused by ApoE defect. 3 and E sound similar. It is caused by ApoE defect. And ApoE is an apoprotein of remnants. So in this condition, remnants accumulate. So we call this condition as remnant disease. Okay, type 3 hyperlipoproteinemia caused by ApoE defect is called as remnant disease. In remnant disease, you see a band here. So what will happen to the beta band? Beta band looks broader. That is why you call type 3 hyperlipoproteinemia as broad beta disease. That is why you call this condition as broad beta disease. It is also called as familial dysbeta lipoproteinemia. Why do you call it as familial dysbeta lipoproteinemia? Because you see a broader band in the beta region. So what are the conditions that you will be able to make a diagnosis using lipoprotein electrophoresis? If you see a band at the point of application, it is lipoprotein X, which is because of LCAT deficiency or because of obstructive jaundice. If you see a broad beta band, it is broad beta disease or familial dysbeta lipoproteinemia or remnant disease or type 3 hyperlipoproteinemia. Got it? So tell me what is the right answer here. So this is the graph that is shown to you. This is the electrophoretic pattern that is shown to you. They've called this as normal. This is the patient sample. This is the negative electrode, which means migration starts from here. And at the point of application, you see a band. If you see a band at the point of application, what will you suspect? Lipoprotein X. Because of what? Thanks, Yungi. Yeah. So tell me, what is that band? This is lipoprotein X, which is because of complete LCAT deficiency. Why am I calling it as complete LCAT deficiency? Had it been partial LCAT deficiency, they would not have presented with chronic kidney disease. Here they have given you chronic kidney disease. That is why it is complete LCAT deficiency. Okay. So this is a very simple MCQ about ninhydrin test. So 1 ml of ninhydrin reagent was taken in 3 test tubes. Can you start answering? Can you try answering? Few drops of solution A, B and C were added to the 3 tubes and were kept in a boiling water bath. So let me tell you few facts about ninhydrin test. All that you will have to remember is ninhydrin reacts with amino acids with alpha amino groups. Ninhydrin will react with amino acids with free alpha amino group to form a purple colored complex. So if you see purple colored complex, it means there is an amino acid with an alpha amino group. Whereas the same ninhydrin reagent will react with amino acids to give yellow colored complex. So if you see an yellow colored complex, it means there is an amino acid. Can you all tell me what are the amino acids that we have? The 2 amino acids are proline and hydroxyproline. So we know for sure C is going to be either proline or hydroxyproline. Just with that hint, what is the right answer, all of you? Because you know C is proline or hydroxyproline, what is the right answer? The right answer is C. And it is further confirmed by the fact that A is an amino acid, lysine is an amino acid. B, you don't get a color at all. If you don't get a color, it's not an amino acid. And obviously, it's fructose, which does not give a color. So what is the right answer here? The right answer here is choice C. Okay, so ninhydrin reacts with amino acids to give purple color, amino acids to give yellow color. Now this is a test used to detect the presence of proteins. Which of the following is true? Who wants to answer this? Which is the color reaction that is used to detect the presence of proteins? It is Biuret test. Okay, so tell me what is this test that is shown to you in this image? It's Biuret test. And as far as Biuret test is concerned, let me tell you one fact. Let me tell you the principle of Biuret test. Compounds containing 2 or more peptide linkages. Please listen to this carefully. Compounds containing 2 or more peptide linkages will react with copper sulfate in strong alkaline medium to give a purple colored complex. Okay, so only compounds containing 2 or more peptide linkages can answer Biuret test, which means only tripeptides and above can answer Biuret test. Because what is a tripeptide? It's a misnomer. The moment you hear the word tripeptide, you would tend to think that there are 3 peptide linkages. No. What is a tripeptide? Tripeptide is something with 3 amino acids. Okay, tripeptide has got 3 amino acids and 2 peptide linkages. So only tripeptides and above can answer Biuret test. Dipeptides cannot answer Biuret test. Now, can you tell me the composition of Biuret reagent? I've already given you a clue about the first component of Biuret reagent. I said copper sulfate, right? So what is the first component? The first component is copper sulfate. So the first component is copper sulfate. The second component is alkaline medium. The second component should provide the alkaline medium that is required, and that is sodium hydroxide. And the third component is sodium potassium tartrate, which stabilizes the solution. So all of you tell me what is the composition of what is the composition of Biuret reagent? Biuret reagent has got copper sulfate, sodium hydroxide and sodium potassium tartrate. So have you heard of something similar to this before? Benedict solution and Biuret solution are almost similar, so you might get confused in the exam. So let me help you compare and contrast between Benedict's and Biuret's reagents so that you don't get confused during the exam if at all it is asked. Okay. So what will be the source of copper? What will be the source of copper for Benedict's reagent and Biuret reagent? In both the cases, it's the same copper sulfate. Okay. And what is the provider of alkaline medium? Alkaline medium in Biuret reagent is a stronger alkaline medium that is provided by sodium hydroxide. Whereas in Benedict's reagent, it is sodium carbonate. Okay. And what stabilizes the solution? Benedict's reagent, it is stabilized by sodium citrate. Whereas in Biuret reagent, it is stabilized by sodium potassium tartrate. Okay, so these are the differences between Benedict's reagent and Biuret's reagent. Yeah, I'm repeating it. Yeah, so let's not have this discussion. Yeah, let's forget about it. Let's concentrate on the reading part. Let's concentrate on understanding concepts and learning facts. Okay, so don't get distracted by any of the discussions here. Just watch the session. So what are the differences between Benedict's and Biuret's reagent? The source of copper in both Benedict's and Biuret would be copper sulfate. What provides the alkaline medium? I told you Biuret will be answered only in strong alkaline medium. So Biuret reagent has got sodium hydroxide, whereas Benedict's reagent, that is sodium carbonate. Stabilizing solution for Benedict's reagent is sodium citrate. For Biuret reagent, it is sodium potassium tartrate. So now you know the composition of Biuret reagent. And before we continue discussing it further, what about urea? Can anybody tell me the formula for urea? The formula for urea, C double bond O, NH2, NH2, right? Formula for urea, C double bond O, NH2, NH2, which means there is only one peptide linkage. And do you think urea will be able to answer Biuret test? No, because there is only one peptide linkage. It cannot directly answer Biuret test. But urea on heating, two molecules of urea will condense to form something called as Biuret. Okay, and that Biuret will be able to answer the Biuret test. That is why it's called as Biuret. Do you understand this? So urea directly does not answer Biuret test. Urea on heating, it forms a molecule called as Biuret, which will answer the test. Okay. Can I make these notes for PG also? Yes, you can. You can, NEET topper. So tell me, what is the answer for this question? This is a test used to detect the presence of proteins. Which of the following is true? The composition is Biuret and copper sulfate. If you're asking, should I write it? You don't have to write it. Just download the PDF and read it. Okay. So the composition is Biuret and copper sulfate. Is that true? No. What is the composition? Composition is copper sulfate, sodium hydroxide and sodium potassium tartrate. So A is false. B, proline gives a positive result. What is proline? Proline is an individual amino acid, and this does not have even one peptide linkage. Even compounds containing two peptide linkages will not be able to answer it, right? Only two and more can only answer. Because it does not have peptide linkage, proline will not answer this test. Okay, it's not answered by dipeptides. That is true. What are dipeptides? They have two amino acids linked by only one peptide linkage. So this is a true statement. Biuret test is not answered by dipeptides. Urea does not answer this test is false, because urea on heating can answer Biuret test. Okay. Thank you, Anuya. I'm happy that you find it easier now. A person gives a urine sample for a routine screening test. Benedict's test result is as follows. So what is the image telling you? The image is telling you that one is control, which is blue in color. The other one is urine, which is red in color. Okay, so blue becoming red. Why kya naam hai Biuret? Say Biuret. I don't understand your question. Okay, so blue has become red, right? So this is a positive result. So when will you see positive result? Parth, Makwana, if you can, if it's a question, can you please repeat it? I'm not able to understand your question. So blue becoming red is Benedict's test being positive. The question is, all of the following can be a cause except. What do you think is the right answer, all of you? In which condition do you think Benedict's test will not be positive? Answer is multiple myeloma. Why will multiple myeloma answer Benedict's test? In multiple myeloma, what will you find in the urine? You will find only Benz-Jones protein in the urine. What are Benz-Jones protein? These are light chains, right? These are light chains of immunoglobulin which get excreted in the urine. Benz-Jones protein will not answer Benedict's test. So what is the right answer here? The right answer here is multiple myeloma, because Benedict's test is answered by only reducing sugars. So can you tell me what are the clinical conditions wherein reducing sugars can be found in urine? It can be a physiological condition or a pathological condition. The only physiological condition wherein reducing sugar can be found in urine is pregnancy or lactation. Because in both pregnancy and lactation, lactose will be formed by the person, and this lactose can be found in urine, and lactose is a reducing sugar. Okay, what is lactose made up of? Lactose is made up of galactose and glucose. This can be asked as an one-liner. Lactose is a disaccharide. Okay, lactose is a disaccharide which is made up of galactose and glucose. Now, what are the sugars that can be present in yes, galactose is reducing titir. You're right. So, what are the carbohydrates, or what are the reducing substances which can be found in pathological conditions? It can be starting from the most common sugar, which is glucose. Yeah, number 1 is glucose. Number 2 is galactose. Yeah, glucose, galactose, fructose or pentoses. It can be glucose, fructose, galactose or pentose. Okay. So, can you tell me what are the conditions wherein glucose is found in urine? I am going to write it down. What are the conditions wherein glucose is found in urine? The most common condition wherein glucose is found in urine is diabetes. But apart from diabetes, it can be renal glycosuria. What do you mean by renal glycosuria? Even when the plasma glucose is normal, if the renal threshold is reduced, then glucose will be found in urine. What is the threshold for glucose? The renal threshold for glucose is 180 milligram per deciliter, which means only when the plasma glucose is above 180 milligram per deciliter, it is going to be found in urine normally. But in renal glycosuria, if the renal threshold is reduced, even when the plasma glucose is normal, it will be found in urine. So that is renal glycosuria. Very good. Excellent. And the third one is alimentary glycosuria. Yeah, the third one is alimentary glycosuria. What do you mean by alimentary glycosuria? For any reason, if there is an increase in the rate of absorption of glucose along the intestine, in the immediate postprandial phase, there will be a rapid absorption of glucose to the extent that it crosses 180 milligram per deciliter. So, in the immediate postprandial phase, glucose will be found in urine. Later on, it won't be found. That is why it's called as alimentary glycosuria. So, these are the conditions wherein glucose can be found in urine. Now, what are the conditions wherein fructose can be found in urine? Fructose can be found in urine in two conditions. One is essential fructose urea. Okay, essential fructose urea. The other one is hereditary fructose intolerance. The other one is hereditary fructose intolerance. Essential fructose urea is caused by the defect of fructokinase. All of you please memorize all the facts as and when I tell you. Essential fructose urea is caused by the defect of fructokinase enzyme. Hereditary fructose intolerance is caused by the defect of aldolase B. It is caused by the defect of aldolase B. In both the conditions, fructose will be found in urine. Glucose is a reducing sugar. Fructose is a reducing sugar. Galactose is a reducing sugar. Pentose is also a reducing sugar. Okay. Now, what are the conditions wherein galactose can be found in urine? That will be called as galactosemia. Right? And galactosemia can be caused by either galactokinase deficiency. It can be caused by either galactokinase deficiency or galput deficiency. What do you mean by galput? Galput is galactose 1-phosphate uridyl transferase. Yeah, galactose 1-phosphate uridyl transferase deficiency. That is called as classical galactosemia. Okay, so in these conditions, galactose will be found in urine. In which condition pentosis will be found in urine? Pentose will be found in urine in hereditary or essential pentose urea. What is it called as? It's called as essential pentose urea. So in all these conditions, urine will answer Benedict's test. Okay. So tell me, what are the conditions wherein urine can answer Benedict's test quickly? Urine will answer Benedict's test in physiological conditions or pathological condition. The only physiological condition is pregnancy or lactation, wherein lactose can be found in urine. Lactose is the only disaccharide that you can find in urine. Is that clear, all of you? Lactose is the only disaccharide that can be found in urine. And what is lactose? It's made up of galactose and glucose. Now, what are the pathological conditions? In pathological conditions, you can find glucose, fructose, galactose or pentose. Okay. So, what is the right answer here? The right answer here is multiple myeloma. In pregnancy, yes, it will be positive. Fanconi syndrome is a form of renal glycosuria wherein renal threshold is reduced. Galactosemia, galactose will be found in urine, which is a reducing substance. Okay. PDF, I will ask them to share it tonight or tomorrow. It will be done immediately. Okay. Yes, classical galactosemia is caused by galput deficiency. So answer this question. A person gives a urine sample for a routine screening test. Benedict's test is positive. Below is a result of Barfoed's test. Okay, after Benedict's test is positive, we perform Barfoed's test. A little information about Barfoed's test. Barfoed's test will be answered only by monosaccharides. Do you understand this? Barfoed's will be answered only by monosaccharides. So what is the application of Barfoed's test? It will help you in differentiating. It will help you in differentiating reducing disaccharides from monosaccharides. Okay. And what will Barfoed's test positivity mean? Have a look at this image. The first 3 tubes, it is positive. The last 2 tubes, it is negative. So what is positive Barfoed's test? If you see a red color precipitate, it is positive. And if it's positive, it means it is monosaccharide. If it's negative, it means it's a disaccharide. Now tell me, what is your identification here? All of you answer this. Is it positive or negative? This is negative. When Benedict's is positive but Barfoed's is negative, it means it's a disaccharide. Which disaccharide can be found in urine? Lactose. In which condition lactose will be found in urine? It is pregnancy. Got it? In which condition lactose will be found in urine? It is pregnancy. Is it not simple? Yeah, all these are bedside tests. Yeah, all these are bedside tests which you can use to find out many clinical conditions. Okay. So answer this. Identify the structure B. Let's try to discuss some genetics question now. Identify the structure B. So what is A? What is B? What is C? What is D? What is E and F? Who wants to answer this? So this is Dr. RJ says it's nucleosome. Okay, you think it's nucleosome. Ponmalar says it's 10 nanometer fibril. Ponmalar is right. Very good, Ponmalar. The answer is 10 nanometer fibril. Okay. So let me tell you what is A. A is a naked double-stranded DNA. So tell me, what is a chromosome in the first place? I would like to ask you all this. What is a chromosome? The chromosome which you draw with a centromere, a short arm and a long arm is nothing but one long double-stranded DNA which has got condensed with the help of proteins. Is that clear to all of you? Yeah, what is one chromosome? The one chromosome which you draw with a centromere, a short arm and a long arm is nothing but one long double-stranded DNA which has got condensed with the help of proteins. So whenever you say I have 46 chromosomes, you mean to say you have 46 double-stranded DNAs. Why do you have to condense these double-stranded DNAs into chromosomes? Because if you uncondense a chromosome and have it as a naked double-stranded DNA, it is going to measure a few meters long. Will you be able to pack such a long double-stranded DNA inside a nucleus which is a few microns in diameter? No. So to enable package, you have to condense the double-stranded DNA into chromosome, and for this condensation, you use histones. Now, what are histones? Histones are basic proteins. When I say they're basic, I mean to say they are positively charged. Okay. Now, how about the charges of DNA? You know, histones are basic proteins. They are positively charged. And how about the charges of DNA? DNA is negatively charged. So, there is an electrostatic attraction between positively charged histones on one hand and negatively charged DNA on the other hand, so that a segment of double-stranded DNA gets wound around histone. And this gives the first level of compactness to your chromosome. Okay. Now, how many types of histones do we have? We have 5 types of histones. What are the 5 types? We have H1, H2A, H2B, H3 and H4. Out of these 5 types, all except H1, the remaining 4 form dimers. Out of these 5 types, all except H1, the remaining 4 form dimers. When 4 form dimers, you call it as an octamer. So this histone octamer sits in the center, which is rich in positive charges, and that attracts a segment of double-stranded DNA which gets wound around. So this string on bead appearance, what is a string here? The string is a segment of double-stranded DNA. What is the bead here? The bead is a histone octamer. So this string on bead appearance is called as a nucleosome. So if you are asked which histone is not present in the nucleosome, do you all understand what is nucleosome now? Nucleosome is just the histone octamer in the center surrounded by a segment of double-stranded DNA. Which histone is not present in nucleosome? H1 histone is not present in the nucleosome. So several such nucleosomes exist. I want you to imagine that you have taken a long thread. On this long thread, you have placed beads at various places. You have allowed the thread to wind around beads. Analogous to that, what have you done? You have taken a long double-stranded DNA. On this long double-stranded DNA, you have placed histone octamers at various places. You have allowed the double-stranded DNA to wind around histone octamers. So several such nucleosomes exist, and these nucleosomes will be connected by a linker fragment. Do you understand this? That will be connected by a linker fragment. And H1 histone is present only in the linker fragment. Now, one such fibril is called as a 10 nanometer fibril because the width is 10 nanometer. Yeah, because the width is 10 nanometer, you call it as a 10 nanometer fibril. Now, you take a segment of this 10 nanometer fibril and you allow it to get folded on itself. Don't you think this is like a beta pleated sheet? How do you form a beta pleated sheet? You take a segment of polypeptide chain, you allow it to get folded on itself. Analogous to that, here you have taken a 10 nanometer fibril, you have allowed a segment of 10 nanometer fibril to get folded on itself. Now the width increases, that is called as 30 nanometer fibril. This is where you get the second level of compactness. Where do you get the first level of compactness? When the double-stranded DNA binds around histone octamer, you get the first level of compactness. You get the second level of compactness when the 10 nanometer fibril gets folded on itself to form 30 nanometer fibril. Now you take this 30 nanometer fibril and you form loops on chromosome scaffold. In your nucleus, you have 46 chromosome scaffolds, one for every chromosome. What are these chromosome scaffolds? They are just tubular proteins which sit in the center for you to form a chromosome. So on this chromosome scaffold, you form loops with 30 nanometer fibrils. So this 30 nanometer fibrils goes all around the chromosome scaffold on all 360 degrees. And it spirals around this chromosome scaffold for you to get a highly condensed chromosome which has got a centromere, a short arm and a long arm. Do you all understand this? So whenever you see a chromosome with a centromere, a short arm and a long arm, I want you to visualize it as a structure which has got a central chromosome scaffold, a tubular protein, on which you have formed loops with 30 nanometer fibril on all 360 degrees and it has spiraled around it. Okay, so now can you look at it and tell me the right answer? So what is the right answer here? What is A? A is a naked double-stranded DNA which does not have any histones. And here you have placed histone octamers. This structure is called as nucleosome. But several such nucleosomes are connected by a linker fragment. This is called as 10 nanometer fibril. And this 10 nanometer fibril has now formed a 30 nanometer fibril. Okay, and that has formed a chromosome, and this is the nucleus. So the right answer here is 10 nanometer fibril. Okay, the structure B is 10 nanometer fibril. So based on the image provided, what is alpha sheet? You are asking about alpha helix, Titish Surai. If you are asking about alpha helix, that's a secondary structure that is seen in polypeptide chain. So when you have a polypeptide chain, a segment of polypeptide chain can get oriented to form an ordered unit like this. This is an alpha helix. Or a polypeptide chain can get folded on itself, that is beta pleated sheet. So this is alpha helix, this is beta pleated sheet. Both are secondary structures of a polypeptide chain. Okay. So based on the image provided, which of the following is not a heterochromatin? So not a heterochromatin in the sense they are asking which is a euchromatin. Euchromatin here is something which is uncondensed. Do you see that all these are condensed and they are more stained? Yeah, all these are condensed and they are more stained. So anything which is condensed and more stained will be heterochromatin, including this. This is heterochromatin. So this is uncondensed, which is euchromatin. So answer is C. But let me tell you about types of chromatin. I'm going to tell you about that now. Come on, 600. Listen to this. That's what I'm going to tell you now. Okay. So before we start discussing about types of chromatin, what do you mean by condensation, uncondensation of chromosome? When will you want to condense your chromosome? To enable package. Whenever you're trying to pack your chromosome, whenever you're trying to pack a double-stranded DNA, it will be condensed. But when the double-stranded DNA has to perform its functions of replication or transcription, yeah, if a double-stranded DNA has to perform its functions of replication or transcription, then both the cases there should be unwinding. To mediate unwinding, there should be uncondensation first. So as long as your double-stranded DNA does not perform any of its functions, it will be condensed. When it has to perform its function, it will be uncondensed. Okay, so that's an introduction. Now, what are the types of chromatin? There are two types of chromatin. One is euchromatin, the other one is heterochromatin. What is euchromatin? Euchromatin is transcriptionally active region of a chromosome. When I say it's transcriptionally active, will it be condensed or uncondensed? For it to be active, it has to be uncondensed. When it is uncondensed, it will stain less densely. In contrast, what is heterochromatin? Heterochromatin is transcriptionally inactive region of a chromosome. When it is completely inactive, to enable package, it has to be highly condensed. When it is highly condensed, it stains more densely. Have you all seen GMSA stained chromosome? Yeah, G banding. G banding of chromosome is nothing but GMSA staining of chromosome. In such G banded chromosome, you'll always see alternating dark and light bands. So if you see dark band, it means it is inactive. If you see light band, it means it is active. Active is euchromatin, inactive is heterochromatin. Okay. Now, what are the types of heterochromatin? One is constitutive heterochromatin, the other one is facultative heterochromatin. Okay, what is constitutive? Something which happens always. Constitutive heterochromatin is something which is transcriptionally inactive always. So, where in your chromosome you'll find something which is inactive always. One is centromere, the other one is telomeric ends. Why will you want transcriptionally inactive region in the centromere? It is because, do you know that in cell cycle, yeah, in mitosis, you know that the chromosome would be already duplicated, okay, and in mitosis there is a phase called as metaphase, and in metaphase mitotic spindle is formed and it gets attached to the centromere. Are you all with me? Yeah, in mitosis the chromosomes are already duplicated, and in metaphase mitotic spindle is formed, it gets attached to the centromere. And then in anaphase, when the mitotic spindle contracts, the centromere breaks longitudinally, and one long arm and one short arm goes to one pole, the other long arm and the other short arm goes to the other pole. So centromere is a region which is subjected to repeated breakage. And breakage will never be perfect. There will be tendency for one of the two cells, yeah, there will be tendency for one of the two chromosomes to gain some of the sequences. There will be tendency for the other chromosome to miss some of the sequences. So can you tell me what would have happened if nature had provided a centromere with something which is coding? Had it been provided with coding sequences during metaphase and anaphase, when the centromere breaks, one cell would have undergone duplication of genes, the other cell would have undergone deletion of genes, both of which are detrimental. And because nature knows that centromere is subjected to repeated breakage, nature has provided your centromere with non-coding sequences. And because they are non-coding, they are highly condensed. And because they are highly condensed, they stain more densely. And because they stain more densely, you mark it as a dark dot. Do you all understand this? How much of time is left? I will continue for another 15 minutes. Come on, 600. Have you understood this? That is how a centromere is formed. So though you mark it as a dark dot, what does it mean? It means it's again a double-stranded DNA which does not have any coding sequence, so it's highly condensed. Okay. Now, why do you want constitutive heterochromatin in the telomeric ends? You want it in the telomeric end because following every cell division, telomeric end undergoes progressive shortening. Do you all know that? Following every cell division, the telomeric end undergoes progressive shortening. So tell me what would have happened if telomeric ends were provided with coding sequences. Following every cell division, the daughter cells would have undergone deletion of gene sequences, which is very dangerous. And that is why both along the centromere and along the telomeric ends, we have constitutive heterochromatin. Okay. Now about facultative heterochromatin, it is sometimes active and sometimes inactive. Example for facultative heterochromatin is female X chromosome. What do you know about female X chromosomes? You know that those somatic cells of all females have two X chromosomes. Only one of the two X chromosomes is transcriptionally active. The other X chromosome is inactive. And because it is inactive, it is highly condensed and it stains more densely as bar body. Don't we know that? Because it is highly condensed, it stains more densely as bar body. So understood, bar body is heterochromatin, it is transcriptionally inactive. But why am I calling it as facultative heterochromatin? When I compare two somatic cells, it's not always the same X chromosome which is inactivated. An X chromosome which is active in one somatic cell will be inactive in the other and vice versa. And that is why we call it as random inactivation of X chromosome. And because X chromosome is randomly inactivated, it's sometimes active, it's sometimes inactive. That is why it is facultative heterochromatin. Got it? So that's about types of chromatin. So what are the types of chromatin? As I told you, chromatin is of two types, euchromatin and heterochromatin. And look at this image. Tell me about A. What is A? A is telomeric end. And we know telomeric end is always a heterochromatin. And then B is centromere, is always a heterochromatin. What is D? Do you see that here? D is present within the somatic cells of females, that is bar body. That is facultative heterochromatin. Whereas what is C? C is the arms of chromosome. Arms of chromosome will have genes and these genes have to be euchromatin part. Okay, so the answer here is C. Okay. The most probable antibody detected in this condition is anti-thyroglobulin antibody, anti-gliadin antibody, anti-transglutaminase antibody, long-acting thyroid stimulator antibody. What do you think is the right answer? Very good. Oxytocin junkie is right. It is long-acting thyroid stimulator antibody. I have no idea why you chose that name, oxytocin junkie. That's an interesting name. It's a long-acting thyroid stimulator antibody, otherwise called as LATS. Okay, so first make the diagnosis. What is the diagnosis here? Do you see a goiter? Yeah, there is a woman who is presenting with goiter exophthalmos, right? Goiter exophthalmos, pretibial myxedema and clubbing. Put together, what is your diagnosis? It is Graves' disease. Tell me, what is Graves' disease? Graves' disease is an autoimmune disorder wherein autoantibodies are directed against TSH receptors. Autoantibodies are directed against TSH receptors. And the effect of autoantibodies binding onto these TSH receptors is that TSH receptors are made hyper-functioning. What will happen when TSH receptors on the thyroid gland are hyper-functioning? Thyroid gland will undergo hyperplasia, and that causes goiter. And it stimulates thyroid gland to release more thyroid hormone into circulation. That causes features of thyrotoxicosis. So what are the features of thyrotoxicosis that you can expect in this patient? They'll present with heat intolerance, weight loss, tremors, right? So all these are hyperthyroidism manifestations that you will see here. Usually you see goiter to be accompanying hypothyroidism, right? Usually you see goiter to be accompanying hypothyroidism, because whenever there is hypothyroidism, there is low FT3 and low FT4. There will be feedback stimulation of TSH. That TSH stimulates thyroid gland to undergo hyperplasia. So goiter and hypothyroidism are usual combination. But if you see goiter and hyperthyroidism, then what should you suspect? You should suspect Graves' disease, which is an autoimmune disorder. And these autoantibodies cross-react and they bind with pre-adipocyte fibroblasts. These autoantibodies cross-react with the TSH receptor analogs which are present on the pre-adipocyte fibroblasts of retroorbital tissues. So in the retroorbital area, if fibroblasts get activated, they release cytokines. And these cytokines will cause edema, and this retroorbital edema is the cause for exophthalmos. So what is the reason for exophthalmos? Because of pre-adipocyte fibroblasts in the retroorbital tissue getting activated, releasing cytokine. And the same is the reason for pretibial myxedema and clubbing. Okay, so what is the right answer, all of you? What are you asking about? Myxedema, colloid goiter. Hypothyroidism is a feature. Right here we are talking about hyperthyroidism and goiter. And the antibody that is secreted in Graves' disease is called as long-acting thyroid stimulator antibody or LATS antibody. Okay. So this will be the last MCQ for this session. A 42-year-old man presents with hypoglycemia. He is a known patient of tuberculosis with poor adherence to treatment. He was treated with dextrose, and before discharge, he wanted a dermatological opinion for hyperpigmentation of gums, dorsum of the tongue and joints. The dermatologist suspected Addison's. So you're not expected to make a diagnosis. They have given you elaborately all the features: hypoglycemia, known patient of tuberculosis, and then there is hyperpigmentation. But they've given you the diagnosis also, it is Addison's. But the question is, what is the cause of hyperpigmentation? Can you see it now? Yeah, can you see it now? These are the choices. Okay, I will read it out for you because I cannot go away from here. So the cause of hyperpigmentation, Addison's diseases. Glucocorticoid stimulates MSH is choice A. ACTH has MSH activity. ACTH and MSH are synthesized from pro-opiomelanocortin. Autoimmune process stimulates pigmentation. If at all autoimmune process causes something to do with pigmentation, it will cause depigmentation. It is not going to cause hyperpigmentation. So what is the reason for hyperpigmentation, Addison's? It is because ACTH and MSH are synthesized from pro-opiomelanocortin. Answer is choice C. Okay, answer is choice C. I'm going to explain this to you. So first, what is Addison's? Can you all tell me what is Addison's? Addison's is adrenal cortical failure, right? It is adrenal cortical failure. It is either caused by autoimmune destruction of adrenal cortical cell, or it is tuberculosis mediated destruction, right? It's autoimmune disorder, tuberculosis mediated destruction of adrenal cortical cell. Now, what do you expect in this condition? Your adrenal cortex is supposed to release glucocorticoid cortisol, and it's supposed to release mineralocorticoid aldosterone. Then adrenal cortex fails, there is low cortisol and low mineralocorticoid. And what will you expect as a result of this? When there is low cortisol, there will be feedback stimulation of ACTH. Your pituitary releases ACTH in response to low cortisol. When ACTH is released, ACTH precursor is pro-opiomelanocortin. So pro-opiomelanocortin will be processed to give ACTH and MSH simultaneously. This MSH is the reason for hyperpigmentation. So tell me, why is Addison's patient always hyperpigmented? It is because there is low cortisol, there is feedback stimulation of ACTH. ACTH release is always accompanied by gamma MSH, which causes hyperpigmentation. Okay, when there is low cortisol, you know cortisol is a counter-regulatory hormone of insulin. So that is missing. Something which opposes insulin is missing. So insulin will be hyperactive. What will happen when insulin is hyperactive? There will be hypoglycemia. So Addison's patient will often present with an episode of hypoglycemia. How will you treat a patient with hypoglycemia, all of you? Forget about Addison's. Okay, forget about Addison's. For any reason, if a patient presents with the hypoglycemia, what would you do? You would start dextrose infusion, right? But if you start dextrose infusion in a patient with Addison's, body temperature quickly rises. Yeah, body temperature quickly rises. That is called as dextrose fever of Addison's. What is the reason for dextrose fever of Addison's? It is because cortisol is necessary for water excretion. Yeah, cortisol is necessary for water excretion. Now, in this individual of Addison's, there is no cortisol, so water excretion is affected. So, when you start dextrose infusion, what is dextrose? It is nothing but D-glucose dissolved in water. So, when you start the infusion would be isotonic to plasma, it will be isotonic to cells. So, no movement of water. But soon the cell will start using glucose. But water is not getting excreted because a person does not have cortisol. When water is not getting excreted, water alone will stay back in the circulation. So when water stays back in the circulation, circulation becomes hypotonic. So water will start moving from the circulation into the cell. Right? This causes osmotic swelling of cells. And this swelling of cell will happen in hypothalamus. That causes thermostat disruption. And the body forgets all heat dissipating mechanisms. So the body temperature rises. And what is it called as? This is called as dextrose fever of Addison's. Have you all understood this? Yeah, so what did I tell you? Addison's patient will often present with an episode of hypoglycemia. To treat the hypoglycemia, if you start dextrose infusion, you will have to anticipate an increase in body temperature. That is because of dextrose fever, because cortisol is necessary for normal amount of water excretion. So without cortisol, water does not get excreted, stays back in the circulation, water enters into the cell. Thermostat cells undergo disruption, body heat dissipating mechanisms fail, so body temperature rises. So this is because of low cortisol. What if there is low aldosterone? What is aldosterone supposed to do? Aldosterone is supposed to cause sodium and water reabsorption. Reciprocally, it should cause potassium and H plus secretion. This is not happening. Yeah, no sodium and water reabsorption. So what will you expect? We have seen hypothermia on giving dextrose in some patients. Don't know why. You understood now? Good. Yes. So that's not hypothermia. They shiver, right? They basically shiver. This is because heat dissipating mechanisms get affected. So they start shivering. Okay. Yeah. So what was I telling you? Yeah. So when there is no mineralocorticoid, no sodium and water reabsorption. So what will you see? You will see hyponatremia and hypotension. Yeah, hyponatremia and hypotension. So a patient of Addison's will either present with an episode of hypoglycemia or they present with an episode of hypotension. Because potassium and H plus are not getting secreted, there will be hyperkalemia and metabolic acidosis. So all these are features of Addison's. Okay. So what is the reason here? The reason here is ACTH and MSH are synthesized from pro-opiomelanocortin. Answer is choice C. Okay. Okay, can we discuss this MCQ as the last one? A 5 months old infant presented with unconsciousness, which readily responded to dextrose. What is titration of glycine? Okay, I understand what you're asking about. Let me tell you about that, and probably the next MCQ we'll discuss in the next session. So let me tell you about titration of glycine. So this is a titration curve that is often shown to you. And in any titration curve, what is drawn along x-axis, you will be shown along x-axis pH changes, and along y-axis number of moles of acid or alkali that you add. Yeah, number of moles of acid or alkali that you add. And glycine titration curve will look like this. Yeah, will look like this. It will have two plateaus. So if you see two plateaus, what does it mean? It means even when you add many alkali, even if you add many moles of alkali, at this point there is no change in pH. And at this point there is no change in pH. So these plateau, yeah, these plateau means at these 2 points, glycine is acting as a buffer. Do you understand this? Only because glycine is acting as a buffer at these 2 points, even when you add more alkali or more acid, there is no change in the pH. Okay, and any molecule will act as an effective buffer close to its pKa. So this means its pK is close to this point, and its pK, its another pK is close to this point. Okay, so one pK will correspond to 2, the other pK will correspond to somewhere around 9. So this tells you that glycine has 2 ionizable functional groups. This tells you that glycine has got 2 ionizable functional groups, one of pK around 2, the other of pK around 9. And they often ask you to calculate the isoelectric pH of glycine based on this fact. So how will you calculate isoelectric pH based on this? Isoelectric pH of a substance with 2 ionizable group will be an average of its pKa. So what is the average of its pKa? 2 plus 9 by 2. 11 by 2 will be 5.5. So its isoelectric pH is close to 5.5. Do you understand this? Have I clarified all your doubts? Cool terrapin. So titration curve, what do you have along y-axis? Along y-axis, moles of acids or alkali added. Along x-axis, it's a pH change that happens. And if you see just 2 plateau, it means it has got only 2 ionizable groups. If you see some other amino acid, say aspartic acid or glutamic acid, in that case, you will see 3 plateaus. If you see 3 plateaus, it means it has got 3 ionizable groups. But glycine will have only 2 ionizable groups, and isoelectric pH will be an average of these 2 pKa. Okay. Okay. So can we end the session with this, or do you want anything more to know about? Is there any other doubts that you have? If you have any other doubt, you can type it in the live chat box. I will be more than happy to explain that to you. If you have no further doubts, thanks for patient listening. I will meet you sometime later in another YouTube session. Okay. Which year do you start to prepare for next? To prepare for next, I would say from the first year you should start preparing, because all basic sciences would be essential for you to understand our clinical subjects. And all these are going to be integrated MCQs. So preclinical and paraclinical subjects should be integrated with clinical subjects. So I would say you should start preparing from your first year. Okay, from the very beginning, try to understand all subjects conceptually. Okay. Last question. Sure, I can. I thought you're all tired. Do we discuss this? A 5-month-old infant presented with unconsciousness which readily responded to dextrose administration. On observation, the child had a doll-like face. So doll-like face is nothing but chubby cheeks. Okay, it's just chubby cheeks. With thin limbs and protruded abdomen. Do you see protruded abdomen? That is because of organomegaly. During the second day of hospital admission, the child presented with another episode of hypoglycemia which did not respond to glucagon administration. Ultrasound revealed hepatomegaly and renomegaly. The reason for absence for response. The reason for absence of response to glucagon is. So whenever you see this term, hypoglycemia which does not respond to counter-regulatory hormone administration. That is classical of von Gierke's disease. What is it? It is von Gierke's disease, which is caused by the defect of glucose 6-phosphatase. Okay, and why do you think it does not respond to counter-regulatory hormone administration? It is because when glucose 6-phosphatase is defective, this is an enzyme which is common to both glycogenolysis and gluconeogenesis. And all these counter-regulatory hormones do not have any magic to increase plasma glucose. They manage to increase plasma glucose only by stimulating glycogenolysis and gluconeogenesis. And if it's von Gierke's, it will come and end at which point? Glucose 6-phosphate point. Beyond that, it cannot become glucose. So it cannot increase plasma glucose. So what would be the answer for this question? There is no response to glucagon administration because glucose 6-phosphatase is involved in both glycogenolysis and gluconeogenesis. But now I am going to tell you all about von Gierke's disease. Okay, so tell me about von Gierke's disease. It's caused by the defect of which enzyme? Glucose 6-phosphatase. And what is that you know about glucose 6-phosphatase? Always in biochemistry, you must have been taught that glucose 6-phosphatase is an enzyme of gluconeogenesis. But today I want you to understand that glucose 6-phosphatase is also an enzyme that is necessary for glycogenolysis to increase plasma glucose. Because glycogenolysis is done by glycogen phosphorylase enzyme. And as the name indicates, this enzyme adds inorganic phosphate and it cleaves glycogen with n number of glucose residues. And one glucose comes out of glycogen. That glucose which comes out of glycogen will get added to the phosphate that you're using for cleaving to form glucose 1-phosphate. So tell me, what is the product of glycogenolysis? It is not free glucose. Product of glycogenolysis is glucose 1-phosphate. That glucose 1-phosphate can become glucose 6-phosphate readily. But for this glucose 6-phosphate to reach the circulation, the cell should have glucose 6-phosphatase. So glucose 6-phosphatase is not only an enzyme of gluconeogenesis, it's also an enzyme that is necessary for glycogenolysis to increase blood glucose. In that case, what is expected in von Gierke's disease when glucose 6-phosphatase is defective? Both glycogenolysis and gluconeogenesis cannot increase blood glucose. So it presents as hypoglycemia, which does not respond to counter-regulatory hormone administration because none of these counter-regulatory hormones have any other pathway to increase blood glucose. Is that clear to all of you? Have you understood this? Now, apart from this, when glucose 6-phosphatase is defective, what accumulates? Glucose 6-phosphate accumulates. This glucose 6-phosphate becomes pyruvate. I am going to write down everything. When glucose 6-phosphate accumulates, it enters into glycolysis. It forms pyruvate. This pyruvate becomes acetyl-CoA. And this acetyl-CoA will be used for fatty acid synthesis and cholesterol synthesis. Had you not attended any of my previous sessions, please understand acetyl-CoA is a building block of both fatty acid and cholesterol. So in von Gierke's disease, when glucose 6-phosphate accumulates, it becomes acetyl-CoA, which is used for fatty acid and cholesterol synthesis. Excess fatty acid will be stored as triacylglycerol. Excess cholesterol will be stored as cholesterol ester. And that is why von Gierke's disease patients present with hypoglycemia, hypertriglyceridemia and hypercholesterolemia. And this hypertriglyceridemia is the reason for doll-like faces. Okay, when there is high triglyceride accumulation in the cheek, that causes doll-like faces. Triglyceride accumulates in organs, that causes hepatomegaly, renomegaly. That is why protruded abdomen. Cholesterol accumulation is the reason for xanthomas. They present with multiple xanthomas. Acetyl-CoA on condensation will form ketone bodies. So you see ketosis. The intermediate pyruvate also becomes lactate. So you see lactic acidosis. Do you understand this? The intermediate pyruvate becomes lactate. So you see lactic acidosis. So these are the manifestations of von Gierke's disease. Is it clear to all of you? So tell me, what is von Gierke's disease? Von is 1. Von Gierke's disease is type 1 glycogen storage disorder, wherein the enzyme which is defective is glucose 6-phosphatase. What does it present as? It presents as hypoglycemia, which does not respond to counter-regulatory hormone administration. Additionally, there is hypertriglyceridemia, hypercholesterolemia. Hypertriglyceridemia causes doll-like faces, hepatomegaly, renomegaly. Hypercholesterolemia causes xanthoma. There is ketosis, there is lactic acidosis. Okay. Okay, so what is the right answer here? Glucose 6-phosphatase is involved in both glycogenolysis and gluconeogenesis. Okay. So thank you all. All the best. If you have any doubts, you can ask me anytime. Okay. So see you sometime later.